Thanks for tuning in again this week for our Student Theorist broadcast. Today we are going to discuss all aspects of the comfort theory.
Thanks, Abby. Now we're ready to discuss the background of the theory of comfort. Catherine Kolkaba, raised in Cleveland, Ohio, received her diploma in nursing in 1965 and practiced part-time several years in the areas of medical surgical nursing, long-term care, and home care before graduating with her Master of Science in Nursing in 1987. Now, Kolkaba's focus of study pertained to gerontology, and her inspiration for comfort theory stemmed from her employment as head nurse on a dementia unit. It was through this experience that Kolkaba began to theorize about the outcome of comfort and used coursework in her doctoral program to develop her theory of comfort. Kolkaba's theory of comfort is classified as mid-range due to the simplicity and adaptability of the concepts and relationships with which comfort is defined. Concepts are specific to nursing. It is operational, it applies to a multitude of situations, and propositions are limitless. Now, some major experiences and theoretical sources associated with Kolkaba's theory of care or comfort. It incorporates an extensive review of literature and utilizes multiple sources. Orlando, Henderson, Patterson, and Zerad's incorporations are as follows. Orlando's concept of relief incorporates the belief that nurses relieve the needs of their patients. Henderson's concepts of ease describe 13 unique functions of humans needed in maintaining care. And Patterson and Zerad's concepts of transcendence incorporate the ability of patients to overcome troubling circumstances with the help of the nurse. The compilation of relief, ease, and transcendence in conjunction with the physical, psychospiritual, environmental, and social contexts of care collide to form Kolkaba's taxonomic structure of comfort. Now, the theory of comfort has been meticulously refined and empirically tested for validity and applicability in practice. Initial testing of the theory was performed during Kolkaba's dissertation. Further testing was conducted by Kolkaba and Associates, and empirically tested outcomes have been published. For further support of the theory of comfort entails the following theoretical propositions. Comfort is generally state-specific. Comfort's outcomes is sensitive to change, consistently delivering holistic nursing care enhances comfort, and comfort in its entirety is most effective. Now let's look at the primary sources associated with this mid-range theory. In 2001, Catherine Kolkaba published an article titled Evolution of the Mid-Range Theory of Comfort for Outcomes Research in Nursing Outlook. This article was the primary source of information used to describe comfort theory and the means by which it was developed. It encompasses a detailed description of the theory's development and the processes used as it evolved into the theory of comfort we now know today. The theory of comfort values holistic care as its central core and attests to the fact that when a patient is placed in stressful health situations, nurses are to meet unmet needs of the patient's level of comfort. Such unmet needs require the utilization of nursing interventions to improve patient comfort levels. Thank you.
Hi, my name is Millie Derwin, and today I will explain the nursing meta-paradigm, major central concepts and definitions, major assumptions, and theoretical assertions as they relate to the theory of comfort by Catherine Kolkaba. The four concepts of the nursing meta-paradigm are nursing, client, environment, and health, and they are all related to the theory of comfort in some way. Nursing must first assess comfort needs of the patient, implement ways to improve and address the needs of the patient, and reassess levels after implementation. Comfort can be objective or subjective. Patients come in all forms and can be family, communities, or individuals. Care must be individualized based on the patient. The patient's environment plays a large role in their level of comfort, and can be manipulated in a number of ways by the nurse to increase comfort. Lastly, health is considered optimal functioning of the patient and is individualized. Comfort was best defined by Catherine Kolkaba as the state experienced by comfort interventions and is holistic and strengthened when needs are met. Needs can be met in a variety of ways, including physically, emotionally, physiologically, and spiritually. Good health service behaviors must be sought out by all patients. She believes that comfort is a desirable, holistic outcome that is germane to the discipline of nursing. Catherine Kolkaba had many assumptions about comfort. When patients are more comfortable, they want to be healthier, in turn make healthier decisions, and are more satisfied. The theory of comfort has three major parts. Part 1 states that patients experience increased comfort when interventions made were effective. Part 2 states that patients who participate in increased health-seeking behaviors experience increased levels of comfort. Lastly, Part 3 states that increased participation in health-seeking behaviors resulted in increased quality of care, therefore benefiting institutions. Comfort care must include comfort actions, interventions, and suitable health-seeking behaviors in order to be effective. The theory of comfort is universal and allows nurses to implement care and educate with ease. It can be implemented and reassessed to ensure that patients have reached their goals. It is easily measurable and relevant to practice. The theory of comfort is one that is widely used today and will be in years to come.
Hi, my name is Lane Weibel, and I'm going to discuss concepts and interrelationships related to the theory of comfort. Kolkaba refers to those that receive comfort measures in different ways. She refers to them as prisoners, workers, patients, recipients, communities, and individuals. The comfort needs that these people possess are referred to as healthcare needs, and they generally exceed the patient's own ability to be met. They rely on us to assess these needs and meet them. Now, in most cases, it will be as simple as the patient asking for pain medicine for their abdominal discomfort or asking for an additional pillow or something of the sort. But for the nonverbal or demented patient, they rely on us to see certain signs and symptoms that are associated with discomfort, such as elevated blood pressure or facial grimacing or elevated heart rate. Now, the steps that we take as nurses to meet these healthcare needs are known as comfort interventions, and they are specific to each patient. The Oxford English Dictionary refers to or describes comfort as a means to strengthen greatly. And so regardless of the type of comfort intervention that we use, that's our end goal, is to strengthen greatly. Now, although we as nurses may use the most optimal comfort interventions possible that are specific to that patient, we still have to overcome intervening variables. And what these are, they are forces that affect the patient's perception of comfort or discomfort. They're influenced by past experiences with healthcare. They are influenced by cultural background, by beliefs, by support system, and by their financial status, and also their prognosis. So the trick there for us is to not only implement those comfort interventions that are patient-specific and that are optimal, but to surpass those intervening variables and holistically make that patient comfortable. Kolkaba describes three types of comfort. She describes relief, which is simply when a particular comfort need is met. She goes on to talk about ease, which is a state of contentment, calmness, relaxation, and then we have transcendence. And this is when not only has those comfort needs been met, but the patient has begun to be strengthened holistically. And then comfort is further subcategorized into the context in which that need was met. Was it physical? Was it environmental, psychospiritual, or social? Did the patient simply receive pain medicine? Was the thermostat altered for their environment? Did they get a pillow? Did we get their pastor in to meet their spiritual needs? Or did we help get their family and friends in there for their social support? Those are all things to take into account. Now, we have health-seeking behaviors for patients. These are behaviors exhibited by the patient, and they may be internal, external, and peaceful death. With internal health-seeking behaviors, they're related to emotional and spiritual comfort. External would be more bodily and physical, while external death pertains to whether or not that patient's comfort and dignity was maintained until they expired. Institutions that generally yield higher results in patient satisfaction and in patient comfort are those with institutional integrity, which essentially means that that facility has an ethical structure, a strong moral code, a particular culture there that encourages patient comfort. They have evidence-based practices in which they've implemented into their policies as an institution, and although we as nurses generally do take comfort into account with our assessments and with our patient needs, that helps reinforce that. It helps give us guidelines and always keeps that in the back of our mind when we're trying to get high customer satisfaction. Moving on, we're going to move on to Christina, who's going to talk about logical forms.
Hi, my name is Tina, and I'm going to talk about Kolkaba's theory of comfort. She used induction, deduction, and retroduction to develop her theory. Using induction, she went from specific observations to generalization. She was a head nurse on an Alzheimer's unit when she wondered, how were her nurses preventing further disabilities? She thought of the concept of comfort, and this is where her theory began. Using deduction, she went from generalized to specific. Her thought of comfort, she wanted to test on different levels and in different settings. She used the work of Henry Murray to base her framework of her theory. This is when she decided that comfort could be enhanced over time. Lastly, with retroduction, it's to develop the theory further and to test it in multiple settings. This is when she added the idea of institutional integrity to her theory. Good morning, Mr. Brown. How are you today?
I'm doing well.
Can you rate your comfort for me on a scale of 0 to 10, with 10 being the most comfortable?
Say an 8.
And what can I do today to make you more comfortable?
It's a little cold. Can you turn the temperature up a little bit?
I sure can.
Thank you.
Thanks, Tina. And now I'm going to give to you a clinical scenario. Sally Smith is a 60-year-old white female. Sally has a strong Baptist faith and is a prominent member in her church where she frequently volunteers. Sally is recently divorced and living at home by herself. Her 3 children, Robert, Rebecca, and Riley, have moved up north with their families. She is a 9th grade English teacher at high school in Shreveport, Louisiana. Sally has been recently diagnosed with diverticulitis and has been experiencing uncomfortable symptoms for quite some time. These symptoms have caused her frequent hospital stays and to miss work. Her doctor has put her on antibiotics and a low-fiber diet to help ease some of these symptoms. However, due to frequent attacks of diverticulitis, surgery is recommended to remove parts of the colon containing diverticuli. Sally is reluctant to go through with the surgery for fear of having a colostomy bag. She's afraid a colostomy bag will decrease her chances of meeting people, limit the number of volunteer hours at her church, and that her students will perceive her as weak. She is currently in the hospital faced with the decision of surgery. Martha is the nurse that is caring for her and understands the importance of the comfort theory. Comfort is strengthened when the need for all aspects of comfort are met. The three aspects of comfort Martha must address are relief, ease, and transcendence. She is aware that the context in which comfort can be is physical, psycho-spiritual, environmental, and social. Martha must focus on Sally as a whole and develop a holistic approach to achieve a high level of comfort. Martha creates intervention using the comfort grid to show Sally that she can continue living her life with a colostomy bag and avoid the symptoms of recurrent diverticulitis. Martha consults with GI specialists and other healthcare professionals to individualize a plan of care that allows Sally to continue with her current lifestyle. Martha educates Sally on ways to conceal the colostomy bag and eliminate unpleasant odors. Once Sally has agreed to undergo the surgery, Martha is there for emotional support, reassurance, and education. Standard comfort interventions are used when the GI specialist and the nurse work together to assess Sally, provide medication, and treatment. Martha uses comfort foods for the soul by providing Sally with her favorite soothing music and coordinating visits from church members to provide emotional support. Martha used the comfort rating scale as a questionnaire to determine the level of comfort Sally has experienced before and after the surgery. Sally's comfort rating began to increase once she overcame the anxiety of a colostomy bag and utilized the interventions provided to regain control over her body. Once Sally has become confident, she has realized she can more comfortably live her life and not have to miss work and volunteering times due to disruptive symptoms. Utilizing all aspects of the comfort theory allowed Sally to live a healthier and more comfortable lifestyle. Now I'm going to discuss the implications for advanced practicing nurse. The theory of comfort allows for the advanced practicing nurse to care for the patient in a holistic approach, focusing on interventions related to the patient's level of comfort rather than the application of technology. Comfort is a holistic outcome because it focuses on interventions that come together to achieve the outcome of comfort. Advanced practicing nurses can utilize this theory, providing interventions based on questionnaire results from their patient. Incorporating the comfort theory into practice can allow for higher patient satisfaction.
Today we discussed the theory of comfort by Kolkaba. Her background and her credentials, her experiences that led to her development, the use of the 4 points of the nursing meta-paradigm, her logical forms and application of her theory to research, education, and advanced practice. Thank you for your time, and please pay attention to the comfort of your patient.